Well, thank you, Dr. Olule. That was very interesting. Oh, sure, no problem. All right, the next topic we have is actually going to involve three speakers, and it's aortic valve disease progression and treatment options. We have Dr. James Wright, Dr. Alok Saurav, and Kelly Line. So are the three of them here? The weather's kind of dicey. I wasn't sure if you were able to make it. Okay. All right, so the first thing we have here is the bio, the esteemed bio for Dr. James Wright, correct? Okay. So you are a cardiothoracic surgeon at Essentia Health and Heart Vascular Center. He obtained your medical degree from the University of Texas Southwestern Medical Center and completed your residency in general surgery at the University of Alabama, Birmingham. And you are board certified by the American Board of Thoracic Surgery and Thoracic Surgery. And will it be just you speaking on the topic today, or are the others going to be joining you?
No, the other two will be here as well. Dr. Saurav will also be speaking.
All right, and is he here?
Yeah.
Okay, so Dr. Saurav is a cardiologist at Essentia Health Heart and Vascular Center. He obtained his medical degree from the MKCG Medical College. He completed his residencies in internal medicine at Creighton University and the Institute of Medical Education and Residency. He is board certified by the American Board of Internal Medicine in interventional cardiology, cardiovascular disease, and internal medicine. Okay, so will it be the two of you, or is Kelly joining us as well?
Kelly will correct us as needed.
Okay, well, I know Kelly here shows as an RN, so I'll go ahead and read Kelly's bio as well. So Kelly Line is a registered nurse in ambulatory care at Essentia Health. She received her BS in nursing from the University of North Dakota in Grand Forks. She has worked in the emergency department, intensive care unit, post-anesthesia care, and is it pronounced nephrology? Nephrology transplant clinic. All very esteemed roles. And you're welcome to join us up here as well, or to your point, correct things as needed. So thank you.
Okay. Am I on? I actually did my cardiac training at the University of Iowa, and I'm married to a girl from Park River, so that's how a Texan who trained in Alabama winds up in North Dakota. We're going to talk about the aortic valve. I need the other picture. Okay. These are out of order, so let me get back to the one I'm looking for. There we go. So the aortic valve is actually located between the left ventricle, which is the main pumping chamber of the heart. We're not going to do this. I can't see that little green thing. There you go. Finger. This is the left ventricle, is the pumping chamber of the heart, and the aorta is the main blood vessel that carries all the blood away from the heart. So the aortic valve is right in between these two places, these two locations. And I have a picture. Okay. So somewhere there's a picture of the valve itself. No. Okay. Let me back up a bit. I've got one missing. The valve itself is made out of 3 leaflets or cusps. They're about the thickness of a piece of construction paper. Not very thick at all, quite thin, but extremely strong and very, very pliable. And the... I think your slides are missing. Yeah, they are. Not good. Yeah, that's mine. Nope. Okay, let me just back up a little bit. We will get there. The valve is very pliable so that when the heart beats, these leaflets fly out of the way and there's no obstruction at all to flow of blood out of the heart. And then when the heart relaxes, these things fold back down and they meet in the center so that there's no leakage back into the heart. So the left ventricle only has to pump the blood once. The most common thing that goes wrong with this valve is the leading edge of the leaflets can become calcified. They get little rocks actually on the edge of the leaflet. And when that process begins, the blood flows over the valve turbulently and it makes noise. And that noise is called a heart murmur. So if you hear a heart murmur, if you hear noise when the heart beats, that means that there's something abnormal about that valve. It may work perfectly well, but the calcium on the edge of the valve will make a noise. Over time, the calcium can increase, and ultimately, it will become so severe on the leaflet itself that the leaflet no longer is pliable. It gets very thick, and the big rocks of calcium will obstruct the flow of blood out of the heart, and that's called aortic stenosis. Now, eventually, if the obstruction becomes so bad, patients will present with symptoms. And the symptoms of severe aortic stenosis are angina, or crushing chest pain that is indistinguishable from the pain of coronary artery disease, syncope or fainting spells occurring with exertion. And some people will have near fainting spells. We call them gray spells with exertion. And finally, dyspnea or shortness of breath with exertion. People begin to lose their breath. They can't do as much as they used to, and they will begin to deteriorate. Now, at the risk of being an old person talking about history, this is some information from a study that was published when I was a sophomore in college. It came from the NIH, and they had followed a bunch of their patients with severe aortic stenosis. That's the wrong one. Yes, they followed their patients over years, and this was 1968. So we really weren't very good at replacing the valves yet. And just in deciding who was going to get this new dangerous surgery, they were looking at what would happen to people with symptoms. And so at the NIH, they had followed a lot of people over years, and when they looked back at the history, they found that the average onset of symptoms was age 60. And the average age of death was 63. So what that meant is that if a patient presents with severe symptoms, they need to have something done, and something done soon. Because when the symptoms begin, you're really on the last legs in the natural history of that disease. Now, this is a little more modern study, and people looked at the severity of the stenosis of the valve, and we measure that these days with an echocardiogram. And they found that they had very severe narrowing, less than 0.6 of a square centimeter. Normal is probably 2.5 or 3. They followed people, and within 5 years, almost all of them were dead. So people with severe aortic stenosis are on the last lap of their journey unless you can do something about it. Even more troubling, this came out of Loma Linda University within the last 2 or 3 years. They looked back at their records and found people who presented to their clinic with aortic stenosis that was severe, valve area 0.8, measured by the echocardiogram. And they had 338 of them, and 100 of them had aortic valve replacement, even though they didn't have any symptoms for one reason or another. They had gone ahead and operated on them. 12 years later, 80% of those people were still alive. The other people who did not have surgery, because they weren't having any symptoms, as they followed them out 12 years, only about 30% of them were still alive. So there was a problem with waiting until things became too bad to get done. People needed to be fixed sooner rather than later. Some of these patients got operated on, but they were so late in the course of their disease that they still couldn't get the maximum benefit. Now what's involved in doing this, to do an aortic valve replacement, you open the chest and the first thing you do is hook the patient up to the heart-lung machine, and the machine itself oxygenates the blood and pumps it through the body under pressure. And as long as the machine is taking care of the circulation, then you can stop the heart. Once the heart stopped, the aorta is incised. You don't actually cut the heart. You cut the aorta to look down on top of the valve. The valve is cut out with scissors and pliers and whatever it takes to rake all that calcium out and break it loose. Put a sizer in. Important to use the right size valve. Then you take whichever valve you're using and put sutures through the fibrous annulus of the valve. Suture goes through the cloth sewing ring on the valve. These things are covered with cloth. And then you lower it down and tie these knots and close the aorta up. What can you do that with? Well, let's go back. One more. A little more history. About 1960, two guys named Albert Starr and a Mr. Edwards of the Edwards Company came up with this ball and cage valve called the Starr-Edwards valve. And it was the first really successful mechanical valve. There's a cloth sewing ring. There was a little plastic ball that when the heart beat, the ball would go to the top of the cage, and when it relaxed, the ball would obstruct this so the blood wouldn't leak back. So-called ball and cage valve. And they were very successful for many, many years. Eventually, in the 70s, most of the companies switched to a tilting disc valve, which tilted up this way. It was referred to as moving like a toilet seat, which was a terrible insult to those of us who have dedicated our lives to putting these things in. But in the late 70s, a bileaflet valve, where these things open and close like this, became more popular, and most of the big companies these days for mechanical valves are using a bileaflet valve where these things open and close on both sides, cloth sewing ring. There are several different manufacturers, but they're all kind of the same, honestly. Now, these things work very good. They don't wear out, they don't break, and they last forever. The catch is that this will cause clotting, so you have to take Coumadin every day to keep clots from forming on this valve and breaking off and going to other parts of the body, or from clotting the valve closed. And currently, Coumadin is the only thing that's approved for doing that. People have tried it with other types of drugs, with antiplatelet agents, and it's never been successful unless you continue on Coumadin. And that's a problem for some people. If you don't want a mechanical valve, we can put in a tissue valve. The first tissue valve, and you've all heard of pig valves, but the Hancock company, which has been bought by Medtronic, took the valve out of a pig, and the pig valve is pretty much like the human valve, and they take the pig valve and mount it onto a sewing frame with cloth. And that was the original pig valve. Now, over the years, they've made valves out of cow pericardium, out of pig pericardium. They've even used frozen human valves. Various types of tissue configurations have been used. The tissue valves also work very well. They don't require a blood thinner because they don't cause clots, but they don't last forever. And the current ones that we're using most of, within 15 years, about 10% of them will have to be replaced. And if you follow them long enough, they will wear out and have to be replaced again. That can be done safely, but it's not an attractive prospect for most people. Now, let me get through these. Now, these slides come from the Society of Thoracic Surgeons. That's the largest group of practicing surgeons in the United States. And there is a database that collects information, clinical information about every operation that's done with open heart surgery in the United States. It started in 1990. There are several million patients who have now had their data entered in the database, and they put out reports every few years showing us how we're doing, so you compare yourself with the other people in the field and to show what the field in general is doing. Now, important thing about this one, this was cumulative, showing how many aortic valve replacements were done between 2008 and 2007. That's a 10-year period. There are about 250,000 of these things done in the United States. And an almost equal number were done along with coronary artery disease. So it's a very, very common operation. A lot of people can do it. The mortality of isolated aortic valve replacement, 3% in 2008, down to about 2% in 2017, shows that that it can be done very safely by a lot of people in a lot of places. Despite the fact that many of these patients are very old and sick and have other complicated conditions. What we've not made progress with is the tremendous toll it takes on people to go through an operation of this magnitude. Now, the surgery is safe, it works very well, but it really is a strain on the patient. This shows, for that same 10-year period, the average postoperative length of stay in the hospital. And although the mortality was very low and got a little better over the years, average length of stay for an isolated aortic valve was about 7 or 8 days, and it really didn't change very much, maybe a day. So it's several days in the hospital, and usually 2 to 3 months to recover. And I tell most patients they need to plan on taking about 3 months until they really feel good again and get their strength back, and they're finally over it. So that's a big ordeal. And because of that, there are many people who would benefit from aortic valve replacement, but honestly just are not strong enough to undergo that ordeal. You can get them out of the operating room and out of the hospital alive, but some people just never really get over the strain, and some older people, it just wouldn't be worth it. So that's the shortcoming that we've had to this point, but fortunately, there's a new sheriff in town. This is the volume of surgical aortic valve replacements done in the United States, and I showed up to here, there are about 250,000 done over a 10-year period. Notice that for the first time since the 60s, for the first time since aortic valve replacement was invented, we've begun to see the number of patients coming for surgical valve replacement drop off and decrease. And it's getting even worse in 21. And that's because of the meteoric rise of a new procedure that, without stealing my little brother's thunder, the new procedure is safe. It works really well, but the thing is that it is much easier on the patient, and the recovery is certainly a lot shorter than 3 to 4 months. So Dr. Saurav will tell you about that. Well, this goes forward and this goes back.
Okay.
All right. And I didn't find
Your pointer is not working.
Yeah, I didn't find the pointer very helpful.
Thank you, Dr. Wright. My name is Alok Saurav. I'm the interventional cardiologist here at Essentia Health. I think I'm not loud enough. Okay. And I'm the medical co-director of the structural heart program that deals with the heart valve issues. So I'll speak about the aortic valve disease today, which Dr. Olule and Dr. Wright have started the conversation already. But I'll cover the transcatheter aortic valve replacement part in a little bit more detail. I do not have any financial disclosure relevant to this talk. So basically, I'll cover the following discussion points. Aortic valve, the basic structure and function. What is aortic stenosis? Stenosis means narrowing. Regurgitation means leakage. Symptoms and prognosis of aortic stenosis. and diagnosis and management. So I think you have shown this picture already, Dr. Wright. It's one of the four valves that we have in human heart, and it's one of the most important valves because it serves as the outlet from the heart. This is the door through which the heart pumps blood out into that aorta, which is the largest artery of our body, and from where it branches out and like sends blood to all your vital organs, brain, your legs and all. Uh, so it carries the oxygen-rich blood and sends it to the rest of the body. So this picture basically shows all four valves. Um, the valve that we are talking about, the aortic valve, is right here. So this is the slice of the heart which has like four chambers, as you all know. The right top, which receives the blood from all our veins, which is less in oxygen, that goes through this valve called tricuspid valve to the right side of the heart, from where it gets pumped out into the pulmonary artery, which goes to the lungs and through the pulmonary valve. And this blood, that goes through the pulmonary artery, is less in oxygen, then it goes to the lungs where the gas exchange happens. So basically, it picks up the oxygen and the carbon dioxide is given off. Then that blood then comes through this pulmonary veins to the left heart chamber, which is called the left atrium, and from there to the mitral valve, it comes to the pumping chamber, which is called left ventricle. And the blood here is rich in oxygen, and this blood gets pumped out to the aortic valve, which sits here, right between the left ventricle and the aorta, to the rest of the body. Then it goes to the brain, like all your vital organs, your extremities. So what is aortic valve stenosis? So it's basically narrowing of the aortic valve, and it's one of the most common, in fact, it's the most common reason for valve replacement surgery in the United States. And it's so common that if you live long enough, probably everybody will have aortic stenosis. But still, the statistics say that 1 out of 8 people, about 12% who are older than 75 years of age, they have this condition. So with aortic stenosis, normally, as Dr. Wright has already mentioned, the valve usually has 3 leaflets. It looks like a flower. They have these petals which are called leaflets, and there are 3 leaflets then which are kind of like, they're paper thin. And they're very pliable, flexible. They open and close, and they, kind of like help maintain the directionality of the blood in one way. And when they close, the blood should not leak backward. So with the aortic stenosis, with time, what happens, there is deposition of this calcium material on the valve leaflets and make them stiffer and harder, so they do not fully open. So as you can see here, this is a normal valve, and this is the valve with aortic stenosis, and what is this white specks that you are seeing are calcium material, and they make the valve very thick, less pliable, less flexible. So when it opens, it does not open completely. As a result, it results in a narrowing. And similarly, because of the same reason, when it will close, it will not close completely. When it doesn't close, that will lead to some leakage as well. So it's common to see sometimes, both narrowing and the leakage in the same valve. So since it's a progressive condition, as the narrowing gets, like more and more severe, the heart then has to work extra hard to pump the blood out, because this is, as we mentioned before, this is the outlet through which the heart has to pump blood out. So when you are feeling tired, exercising, like doing some kind of physical activity, so if the valve is not working properly, that could be the reason why you're feeling or having those symptoms. Now, causes of aortic stenosis. So as far as the reasons why you can have the narrowing of the valve, there are several reasons why you can have it. The most common is, as you mentioned, the degenerative process in which the calcium builds up on the valve leaflets, and it's a normal aging process of the valve. A human heart beats about 100,000 times a day, like 40 million times a year. So it's been beating even before you are born. So it's a normal wear and tear process. And as you said, like if you live long enough, you will have this problem. Uh, so that's the most common type or most common cause why this valve gets narrow. And it's typically, seen, like in older folks, who are more than 70-year-old or 70 years or older, that's the average age of presentation of this type of aortic stenosis. Then one is called a congenital or bicuspid type, where instead of 3 leaflets, uh, they are born with 2 leaflets. And this is quite common. 2% of the general population have this condition. And that may or may not progress to aortic stenosis. So this is a valve that is deformed. And as a result of that deformity, it kind of like that wear and tear process kind of like gets more accelerated. So these are the patients when they develop narrowing of that valve. They tend to present at a younger age, like typically 50s, 60s, and these are the patients who will come and tell us, they are not, they have been told that they have a heart murmur since they are, like young or since their childhood age even. So this is the type usually, we suspect when the patients are young and when they say that they are known to have a heart murmur from their 20s or, when they're, from their adolescents. So this is the type, but this is probably the second most common type here in the United States. The third common type is because of the infection. It's not actually an infection, it's like a sort of immune reaction to the valve, to an infectious agent. And this is, fortunately, we do not have this and we do not see this as commonly now, but it's still pretty prevalent in third world, in developing countries. So this is, if might have heard rheumatic fever or rheumatic heart disease. So this is the kind, that's the third most common type of aortic stenosis that you can have. And sometimes rarely because of, radiation treatment to your chest because of the breast cancer or, like some of the blood cancers you may have received. And if you receive in a, pretty big dose of that, so that can sometimes, even if it does not by itself cause or may not cause the aortic stenosis, that can at least, that, I mean, theoretically, it can accelerate the progression of the narrowing of the aortic valve. So again, this picture shows how it goes from totally normal looking aortic valve with 3 curves which are very pliable, like paper thin, to there is more accumulation of this calcium, material, and as in severe cases, they're really, really stiff and they don't open. So this is another picture which is showing the normal opening is size of a quarter. Like as the valve progresses, that narrowing progresses from mild to severe range, it kind of like looks like this. So through that narrow opening, if you have to kind of, if the heart has to eject the same amount of blood each time, so it just, like has to work extra hard. Like there's a lot of pressure generation, in the pumping chamber, and that gets transmitted to the lungs, and that's why patients, they complain of, or most common complaint they usually have with this aortic stenosis is shortness of breath. So risk factors we talked about, aging is the most common. This is something we can help. Like everybody gets old, older, like, and this is something we get. But not everyone who gets old has aortic stenosis. There are certain factors which can accelerate that process, like smoking can accelerate that process. High blood pressure, uncontrolled blood pressure, that can, accelerate the wear and tear of the valve. High cholesterol. This is again has been this is a cholesterol also accelerate that degenerative process of the valve, but in very advanced stage of aortic stenosis where it's already moderately narrow or severely narrow, even if you take some medication for cholesterol, that may not like reverse the process. Family history, there are some genetic association, especially with the bicuspid, the congenital type of aortic stenosis. There is some genetic association and bicuspid is the other one. So we have gone over the symptoms. The most common symptom is shortness of breath. Patients, they describe it, in various forms. They say that they are getting, they are not having as much energy as they used to have. They're feeling too tired easily. They're getting short-winded, and if it progresses, then, it will lead to fluid retention, in their lungs and in their, legs, ankles. So basically, this is the stage when we kind of call them they are in congestive heart failure. They can have some irregular heartbeat, palpitations. But what we are most concerned is that, sometimes because the heart cannot pump enough blood out, particularly when you exercise, because exercise requires for the heart to even pump out 3-4 times more blood, and the valve is already narrow. When the heart cannot pump the blood out through that valve, and accordingly, there's less blood going to the brain, and the patient, they complain of dizziness and lightheadedness. Particularly during exercise. If they're doing any strenuous exercise, they're feeling dizzy, lightheaded, they feel like they're going to pass out, or even they pass out, that's a very ominous sign. Fatigue, dizziness, syncope. Syncope is basically faint or pass out. And chest pain. Some patients, even if they do not have any blockage, they can still have chest pain because of the narrowing of the valve. So, many just kind of try to, downplay it by saying that it's just, they're getting old, but, you shouldn't be, you should be able to differentiate, it's just a normal aging versus, it's something because, something wrong with your heart or with your breathing. So there are certain diagnostic tests. Again, Dr. Wright has alluded to this before, but just we'll go over quickly. Physical examination is very important. What we look for is a sign, for an audible murmur. The murmur intensity can go up. There are certain characteristics of the murmur as the valve, becomes more severe that we look for. But more objectively, we do certain other tests. Like one of them is like sonogram. That's basically the ultrasound that we do on the surface of your chest. That would show how the valve is functioning. That will also show how the heart is functioning, if there is any strain on the heart, if the heart is getting enlarged. So all those things we'll see with that echocardiogram. Then we do the heart catheterization or coning angiogram, where it's a more invasive test where we take a catheter to the vein or the artery in the wrist or through the leg and take it to the arteries of the heart, which supply the blood to the heart muscles itself. And we look for blockages. And this is just an adjunct test to kind of helps us determine which way the aortic valve needs to be replaced, whether it needs open heart surgery versus the one that I'm going to talk about, transcatheter aortic valve replacement. Then we need a CT scan. This is another vital part of the whole workup process that we do CAT scans probably, some of you might have had a CAT scan at some point in your life. So this is basically, they put you in a scanner and they, where we, it's basically an X-ray machine, that would X-ray the valve and tell us what size it is. And, there are valves come in, 3 or 4 different sizes. So we'll pick the size of the artificial valve based on some of the measurements we get from the CT scan. And it also shows us if you have to go through the vein in the leg and to replace this valve, which I'll talk about later, if the vein, the size is adequate to put that catheter in your body. So these are all the different diagnostic modalities we talked about, angiogram on the top left, then the echocardiogram on that side, on the bottom right, and this is the CAT scan, how it looks. So there are different stages. Again, every patient does not, just having the sheer diagnosis of aortic stenosis does not necessitate surgery or some kind of intervention. So the valve kind of progresses through these various stages, which we have classified from mild to severe. And some patients, even if they have some kind of aortic stenosis, they may still remain in mild to moderate stage all their life and may not hence need a valve replacement, because we do not think mild to moderate level of aortic stenosis, at least until until now, based on the studies and all, we do not think that causes you any symptom. Um, but when it becomes severe degree of narrowing, we have certain parameters, like less than 1 centimeter square on the echocardiogram, and certain other parameters we go by, based on which we classify it severe. So that, and with that, if it is severe and if it is causing any symptoms, and even if it is not causing any symptoms, it has caused a lot of strain on your heart, then that would be an indication for the valve replacement. So there has been some guidelines on how frequently you will need to follow up or have that surveillance, which is typically done with an ultrasound. So if it is just mild, like we do a repeat ultrasound every 3 to 5 years. If it's moderate, every 1 to 2 years. And if it's severe, it can be from 6 months to a year, as long as they're symptomatic. If they're symptomatic, then we'll talk to them about valve replacement. Having said that, in patients who are actually severe, and at least they are asymptomatic, at least they claim to be asymptomatic, we have seen that as high as 40% of them, if you have them walk on a treadmill, they'll become symptomatic. So it's a kind of like a very, sometimes the symptoms are very underrated, or they're kind of like they may play it down by saying that it's just the aging process, but actually it's a valve that might be causing them symptoms. So this is something Dr. Wright has already gone through. So there is a long latent period before the valve becomes symptomatic, because we have enough reserve, like with our heart and like any other organs. So sometimes it before the symptoms appear, which there might be, it may take several years, even with that, even the valve has been narrow for a long time. And as the symptoms start appearing, depending upon different types of symptoms, there are some studies which have shown what the median survival is, and median survival can be as less as 60%, as less as 6 months. Like 50% patients will die if they have congestive heart failure symptoms if they are not treated within 6 months. Now the treatment options. So medical treatment, surgical treatment, and the one which you are calling TAVR, which stands for transcatheter aortic valve replacement. It's a basically minimally invasive procedure in which you change the valve by going through the vein in the leg, or the artery in the leg, or through an alternate access sites such as the artery in the arm or through the neck. We can do that, but it does not need any open heart surgery. It does not need any incision or any suturing and all that. Medical management, there is nothing actually really sort of medical management. It may stabilize your symptoms for a very brief period, but it's a progressive condition. It only gets worse with every passing month or every passing year. So when you are symptomatic, the only treatment, if you want to live longer, then either have a valve replacement, either through an open heart surgery or through transcatheter aortic valve replacement. So this is something I'll not talk about, since Dr. Wright has already mentioned this. Surgical aortic valve replacement, that's the acronym for SAVR. So here I'm going to talk about, this is the sort of like the newest technology, and it's been tried and tested in clinical trials since early 2000, but has been commercially available since 2012. So TAVR stands for transcatheter aortic valve replacement. So what it means, we take a catheter through the vein in the leg. That's the most common access site, and in which the valve is already crimped or mounted on, and we take it across the native valve, the patient's own valve, and we deploy it. And it does not need any open heart surgery. We do not need to crack the chest open for this. So the advantage of a TAVR is it's less invasive. It's very small incision, like a 2-3 millimeter incision is made in the a small nick we give in the groin, through which you go, and we put a thin, flexible catheter through the vein or the artery in the leg that leads up to the heart, and then we take that catheter, and the valve is positioned precisely across the native valve. The difference here is that the patient still has his own valve inside. We cannot take it out because this is not an open heart surgery. The native valve still stays there. In fact, it serves as an anchor for the new valve to stay in place. So these are the different, again, diagnostic modalities which I've already talked about. So one of the like the echocardiogram that we talked about, everybody is probably familiar with the ultrasound that we do, by applying some jelly on the chest, and that's a non-invasive way. But sometimes we have something called transesophageal echocardiogram. This is something that gives us a little bit more accurate assessment of the valve. And this is a procedure. It's a 15 minutes procedure. It's done with under anesthesia. They put you under. You don't feel any of that. The procedure itself, it's not a painful procedure as such. But what they do is that they put a probe down your throat, which has a little camera at the tip of it, which is basically a miniature ultrasound probe, and that would give us all these images that that the regular, like a surface ultrasound gives us, but with like more accuracy, and it's a with a better image quality. Then the angiogram we talked about before. We go through the artery in the wrist or through the groin, and I put a small catheter, and we basically look for the blockage in the heart. So these are the arteries of the heart. We supply the heart muscle, and
You got it?
oh, yeah, thank you. Thank you. And sometimes it's important to know if they have any blockage, because that's going to determine which way you want to have this valve replaced. CT scan, that gives us some vital information about the sizing of the valve, what size artificial valve we want, and also tells us about which is the access site we pick, for the valve replacement. Typically, we go to the groin, and most of the time, 90% of the time, we go to the groin. But sometimes there are many with the peripheral vascular disease who have poor circulation problem in their legs. They may have those arteries may not be conducive. There may not be big enough size to take that catheter. So we tend to pick a artery that's good, like one of the arm arteries or one of the carotid arteries. If they look good size, then we can pick one of those. But they're still, less than 10% of the cases that we do. Still, whenever it's feasible, it's always better to do going through the groin. So, so Dr. Wright, actually, he does both surgery and the transcatheter valves. He does both the types, I cannot do surgery, so that's the basically, so even if he says that TAVR has taken over, but surgeons are as much involved as an intervention cardiologist in this process. And structural heart coordinator Kelly, she's the structural heart coordinator with us, so she plays an important part in this whole process. So I'll briefly talk about the TAVR valves. There are only two types of TAVR valves which are currently approved by the FDA, and we have both of those, and they are tissue valves. They are not a mechanical valve, so you do not need any long-term, lifelong blood thinners. You probably just would stay on a baby aspirin for the rest of your life. If you do not have any other indication for to be on a blood thinner, then you just only thing that you need is a baby aspirin. So one on the left is a Medtronic valve. It's a big valve. It's made by the Medtronic company. The other one is the Edwards valve. It's a balloon expandable valve. That's a cow valve. What they do, they harvest the outer layer of the pig's heart or cow's heart, and they kind of like mold it into those leaflets. And there's this metal frame, which is an alloy of nickel and some other material, cobalt and all that. Uh, uh, so which is pretty like resilient but with good tensile strength. So it's they kind of like work a little differently, or how they, but they both the valves have been proven to be effective, with comparable result with the surgical valve. Uh, Now, after we have done the workup, then we kind of like what we have is called a heart team meeting, which involves a cardiac surgeon and it involves a cardiologist, a non-invasive cardiologist who has done the echocardiogram, anesthesia. So we have a meeting about, there's such and such patient, and this is the anatomy of the patient, and this is all other like numbers. Then we kind of like decide which is the best way or a better way to treat the valve. TAVR has its advantage in terms of like it's definitely minimally invasive, but like if you have certain other things like severe coronary artery disease, meaning severe blockage in the arteries of the heart, surgery might be a better option in those cases, because you can all have the do the bypass surgery as well as change the valve at the same time. So a heart team is a multidisciplinary team that collectively evaluates patients, makes treatment decision, and delivers appropriate heart valve therapies. So I'll just try to play this video of the Medtronic valve here. Let's see if it is. So here we are seeing the groin arteries. We place a wire first, and this is one of the catheters that goes. The wire serves as a sort of like a rail over which you take this catheter, and this is the aortic valve. And we slowly release it. As we draw that catheter, the valve opens up. It just flowers out, and we have time to like recapture it and position it differently. If you don't like it, then we kind of like fully deploy it. Then it just starts working immediately, and it stays there in place. There is no suturing involved, nothing. It stays there in place. Then we take the catheter and the wire out. So this is how the Medtronic valve is implanted. Then this is the other one, which is a balloon expandable valve. So here the valve is actually mounted on a balloon. So we take it, like there's a wire that we first put it across the valve, and the whole system comes from the groin. And we take this catheter. That catheter kind of like goes over that wire, which serves as a rail. Then we take it down across to the aortic valve, which is diseased. Then we'll try to position it, make sure that it's in relation to the other structures of the heart. It's well positioned. It's not too deep or not too high. Then, so after making sure that it's positioned well, we may take some pictures. Then we inflate a balloon. Then as you inflate a balloon, it inflates the valve. Then we deflate the balloon, and we draw the balloon and the other system out. And this valve stays in place and starts working immediately. Then finally, we take that catheter out through the groin. And this is a tube or sheath, we call it, through which that catheter whole system goes. Take that wire out, and we put a small suture there. So this valve works, like almost immediately. The whole deployment process takes about 5 to 10 minutes. The patients usually stay in the hospital when they are usually awake when they get back to their room, and they stay in the hospital for a couple of nights. In the earliest, they can have gone home next day, and they have gotten back to their previous level of activity, or the work schedule and everything that they were doing before, and as soon as within less than a week. So recovery is pretty quick. So that's kind of like one of the advantages of this procedure over surgery. Um, as far as the durability and all is concerned, both the procedures have been, like both the valves types have shown equivalent results so far with the surgical valve. Uh, uh, as far as the durability is concerned, again, the comparison was with the tissue surgical valve, not the mechanical valve. The mechanical valve, lasts for lifetime, but these are the tissue valves. So typically so far, again, these valves are only being implanted since last 10, 15 years only. So they have been pretty, there's some data that there's some good durability, like over 90% for up to 10 years. There are some data like that. And if we need a second valve, if this valve degenerates, if we need a second valve, we can do the same procedure all over again, and we put a new valve inside this valve. So that's why this has been kind of like has been very attractive, especially in patients, because this is a disease of the elderly, and when they get old, they also have other kind of like comorbidities, and they may not have the, they may not be in the best shape to survive an open heart surgery. So this is kind of like this procedure has come pretty handy in those cases with really good result and durable result. I think that's all I had. I'll take questions, and Dr. Wright and myself will take questions if you have any.